Hello all, I'm Dr. Kaustubh Mohite, your pediatric pulmonologist. Welcome back to my channel, Pediatric Pulmonology. In this episode, we will be talking about the basics of embryology of respiratory system and its clinical correlation. In the developing embryo, the esophagus and the trachea are not separated. The trachea and the main bronchi are derived from the primitive foregut. The right and the left main bronchi gives rise to two lungs independently. This occurs via a repetitive cycle of outgrowth of epithelial tubes into the surrounding mesenchyme, followed by branching of these tubes. This process is known as branching morphogenesis. Prenatal lung development is mainly subdivided into four stages based on organogenesis, continued branching morphogenesis, epithelial differentiation, and formation of primary septa. These stages include the embryonic stage, pseudo-glandular stage, canalicular stage, and the saccular stage, followed by alveolar stage. Easy way to remember the duration of these developmental stages are 6 to 8 weeks for embryonic stage, 8 to 18 weeks for pseudo-glandular stage, 18 to 28 weeks for canalicular stage, 28 to term for saccular stage, and alveolar stage, which may last till young adulthood. Various reference books may have some minor variation in these timelines. So first we talk about the embryonic stage of lung development. The right and the left main bronchi are formed by outpouching of the ventral wall of the primitive foregut, which further gives rise to the two lungs independently. They elongate and start a repetitive cycle of growth into the surrounding mesenchyme by dichotomous branching, which is called branching morphogenesis. Development of trachea begins with the laryngotracheal groove or sulcus in the lateral wall of the foregut, which deepens and fuses progressively, thus separating the trachea from the esophagus. Cartilage formation starts at the end of the embryonic stage and continues until it reaches the smallest bronchi. It follows the central to peripheral principle. Parietal pleura develops out of the somatic mesoderm, whereas the splanchnic mesoderm gives rise to visceral pleura by 7 to 9 weeks of gestation. At 7 weeks of gestation, the septum transversum is formed by mesenchyme tissue, which separates the pericardial cavity from the abdominal cavity. So why do we need to know so much regarding this stage? Defects in organogenesis are often incompatible with life or causes severe pulmonary morbidities. They are related to the primordium of the lung, which includes pulmonary agenesis, aplasia, to incorrect tracheoesophageal separation leading to tracheoesophageal fistula or esophageal atresia, as well as incomplete closure of pleuroperitoneal membrane leading to diaphragmatic hernias. Next comes the pseudoglandular stage. Branching morphogenesis continues in this stage. In humans, there are on an average approximately 23 generations of branches. However, the number of generation formed depends on the length of the pathway of the future airways. Cellular differentiation is observed in this stage as the first ciliated, goblet, and basal epithelial cells, as well as alpha smooth muscle actin positive cells, are detected during this stage. The alpha smooth muscle actin positive cells forms a continuous layer around the future airways, starting at the trachea and ending proximal to the terminal bud of the developing bronchial tree. These cells start spontaneous peristaltic contractions by pushing waves of interbronchial fluid into the periphery, thus causing a rhythmic extension of the most distal airways, including the terminal ends. Around birth, these contractile cells change from a peristaltic to a static phenotype and regulate the diameter of the conducting airways. Fetal breathing movements start in humans at around 12 weeks, which causes exchange of pulmonary and amniotic fluid and induce lung tissue stretching. So, how significant is this stage of development? Branching morphogenesis is highly dependent on mechanical forces. Compression of the lungs due to a diaphragmatic hernia, oligohydramnios, skeletal abnormalities, or an embryonic tumor may cause different degrees of pulmonary hypoplasias. Hypoplasia refers to a reduced number of generation of the bronchial tree and may cause severe pulmonary insufficiency. Next stage of lung development is the canalicular stage. In this stage, the differentiation of the alveolar epithelia becomes histologically visible, which leads to the recognition of the future alveolar ducts. The cuboidal cells present in the pseudo-glandular stage differentiate to type 1 and type 2 alveolar epithelial cells. Type 1 cells are flat, possess a large surface area, and cover most of the alveolar surface. The type 2 cells stay cuboidal and start to produce surfactant. First gas exchange is observed at the end of the developmental stage. In order to build the first air-blood barrier, the capillaries of the mesenchyme move to the surface of the future alveolar ducts, which is now covered by type 1 epithelial cells. The basement membrane of the endothelial cells and type 1 alveolar epithelium fuse and form a very thin sheet-like structure which optimizes the gas exchange. This is the stage when type 2 alveolar epithelial cells start to produce surfactant. By dynamically lowering the surface tension, surfactant is a prerequisite for the first inflation of the lung after birth. It also prevents the lungs from collapsing during expiration, takes part in the regulation of airspace, increases compliance, and surfactant protein A and surfactant protein D contribute to innate immunity of the lung. Survival is possible if birth occurs towards the end of this canalicular stage, but the infant normally needs assisted ventilation and has a high risk of developing bronchopulmonary dysplasia. Defects in the canalicular stage can lead to conditions called alveolar capillary dysplasia. In the next saccular stage, mesenchyme further condenses, the acinar airway grows in length and width, and primary immature septa are formed. Neonates born at the early phase of the saccular stage present with respiratory insufficiency that needs assisted ventilation and are at a high risk of developing bronchopulmonary dysplasia. In the final stage of alveolarization, lung volumes increases 10 times and the alveolar surface increases 20 times until adulthood. Existing airspace of the future alveolar ducts are subdivided by the formation of new secondary septa. This process is either called alveolarization, which means the formation of new alveoli, or septation, which means the formation of new septa. Platelet-derived growth factor receptor alpha positive myofibroblasts accumulate in the primary septa and produce elastin fibers and collagen fibrils, and alveolarization is initiated at these sites. Alveoli are formed by an outpocketing into the mesenchyme. The alveoli are first lined by the cuboidal epithelium, which later flattens to form the air-blood barrier. It has been observed that new alveoli are formed as long as the lung grows, even after lobectomy in adults. This means that structural damage of the lung could be repaired, as also seen in few cases of late recovery in bronchopulmonary dysplasia. So as we come to the end of this topic, we should have learned these basic few points. Each stage of lung development has an important clinical correlation. Respiratory acini are first observed in pseudo-glandular stage, whereas surfactant appears first in canalicular stage of lung development. Survival is possible if birth occurs towards the end of the canalicular stage, and finally alveolar stage continues until early adulthood. So that completes my comprehensive discussion regarding embryology of lung. I shall be soon coming up with other topics related to pediatric pulmonology, which I am sure will make you understand the topic much better. Thank you.